Hello, and welcome to today's Ask the Expert session, where we're going to be talking about the PainPad and other health tech innovations. My name is Dr. Daniel Gooch. I'm a senior lecturer in computing and communications here at the OU, and I'm going to be facilitating most of today's session. And with that, I'm happy to hand over to Blaine Price, who is going to introduce himself and start the talks.
Hi, I'm Blaine Price. I'm a professor of computing here in the School of Computing and Communications. My specialist area is called human-computer interaction, which is where we study how to improve how computers and people work together. And this talk is going to be about a multidisciplinary journey based on, started by a chance meeting with my colleague, Oliver Pierce.
Hello, I'm Oliver Pierce. I'm an orthopaedic surgeon, a hip and knee specialist, and I have a particular interest with Blaine in monitoring my patients' various parameters, pain being one of my favorites. I want my patients to have less pain. So, how did this journey begin? We're going back, and I always get the year wrong, don't I? 2015? Yes, to 14, see, to a chance meeting. I'd seen Blaine on a TV program, a Panorama, Monitor Me, self-monitoring the night before, and I'd arranged a meeting the following day with various Open University scientists, and we had a chat afterwards. And he said magical words, "What can I do for you?" And I said, well, I've moaned about my patients having pain and how I'd like to improve it, but paper diaries were rubbish. And wouldn't it be nice if we had a device that they could input their pain score on? Why does it matter? Surgery hurts. Actually, patients who see me for a hip or a knee replacement have pain before surgery, but the surgery itself can cause pain. We've shown medically, numerous studies, that early mobilization, getting up the same day as surgery or the very following morning anyway, improves all of the outcomes of surgery. And I wanted my patients to walk within 2 or 3 hours of having what's major surgery. So this is a step forward. But if you're in pain, you can't move. So I wanted to quantify pain in any patient cohort. So we have patient-reported outcome measures and pain scores, and they're pretty subjective, they're pretty noisy. We did have diary collection issues. If you've ever given a patient a pain diary and you get it back at the end of 6 weeks, you can see a pattern which appears to be that they just filled it in the last hour before coming in to see you, and you can't really trust the data, and that's for those who do return the diary in the first place. What would be ideal would be that patients, whilst they're an inpatient, are asked every 2 hours by a nurse how much pain they have. And that happens to some extent, but nurses are very busy and we're short-staffed in the NHS. And nurses also, at the end of their shift, can do this estimating at the end of the shift and backfill. And we see a lot of scores that just say 0 out of 10. And we wonder whether that means they had no pain, the patient, or in fact, it just wasn't recorded. How do we get patients to self-log their pain? Paper diaries was the old way. But Blaine's first suggestion, when I moaned about it enough, was, Ollie, that's an app. And I said, yeah, but I've asked, and only about 50% of my elderly patients actually even have an email address. Remember, we're 2014 here, so things have changed. And so what I wanted was a tangible, a device, something that goes in the hand and is easy to use for elderly patients. So we made some design requirements. It has to fit in the hand. It has to be easy and intuitive to use. It has to be inexpensive. In fact, my words were, it has to have no value. If someone stole it, there's no benefit to them. It doesn't do anything outside of the hospital. It has to be robust because it's going to get dropped. And its battery life had to be at least as long as the average inpatient stay, somewhere between 1 and 3 days. And it has to connect seamlessly with the hospital Wi-Fi. But they are easily swapped to new patients. They have to be easily cleaned and sterilized. And so an alcohol wipe to wipe it clean, because of you don't want it to be a fomite, an inanimate object that can transmit infection. We have elderly patients, weak fingers, arthritic fingers, painful fingers. They're less familiar with technology. Has to be able to fit in one hand, ergonomic. Has to be able to prompt them. So not just sit there and they decide when to input, which they can, but it has to prompt them every 2 hours with a beep and a flashing light. And it has to be secure, wireless data transmission, real time, so that I can see how my patients are doing. Even if I'm not on the ward, I get a graph of their pain. It's very useful. So it did go through some different design iterations, excuse the artwork. The first iterations were tested with our specialist pain nurse, 3 ward nurses, and some researchers. Later designs were tested with patients for feedback, and various improvements from these iterative design technologies were that we added an extra battery, an on and off switch, because when it wasn't being used, it kept beeping, and that does annoy, and improved number entry user interface. The patients also requested a slightly smaller device and, for what it's worth, a brighter plastic so that it didn't merge into the background when it was on the bedside table.
So this is our very first design. We just took some off-the-shelf electronic components, which cost anywhere from a few pennies to a little less than £1. There were 6 items, and we 3D printed a plastic box. This was, you can see the picture here, stuck some LEDs on it so they could flash to attract attention with a little sounder, and a tiny microprocessor called a WeMOS, which connected to the battery, which was the most expensive component, a rechargeable battery. We did a study, first of all, with 54 people, and we set it up to prompt from 8 a.m. to 10 p.m. every 2 hours. The nurses also did their usual pain score collection, and we did a little usability feedback to analyze both the compliance, were the patients, entering the data, and how well they matched between the nurses' score that they collected by asking them and the self-log score. So we can't know the ground truth because we can never know actually how much pain someone was in. But the self-logging appeared to produce what we think are more honest results because they were about 1 pain level out of 10 lower than the nurse score about the same time. We think that's because when you're asked by someone in a busy hospital ward how much pain you're in and you have to answer right away, one, you don't have time to reflect. So you might just give a quick answer that's not accurate, but also you may just not want to trouble the poor overworked nurse and say you're in less pain than you are. So we got a higher pain score when they had a few minutes to reflect and log it themselves. We also got more records because the nurses on a busy ward couldn't always go every 2 hours, and the patients could self-log whenever they wanted, either when the device prompted them or when it occurred to them. And it also, of course, as Ollie said, gave live data, not a retrospective that you look at days later in a medical record. So this is just some pictures of how the design evolved going clockwise from left to right. You can see we ended up with brighter colors near the end, more rounded designs, flatter LEDs, so it's a completely flat, white, clean surface. You can wipe it with a SteriWipe in seconds. And it also, the last one, slides into a docking station, so it can just go back to the nurse's station and easily recharge. We did a second study at the same time just to compare if a tangible device that you can hold in your hand versus a virtual device on a tablet worked better. So you can see a couple designs here. This one was similar to the physical PainPad with a number pad. The other had a slider you could move up and down. It did the same thing. We had about the same cohort of patients, sorry. And the results were overall the tangible device, the handheld PainPad, was ranked highest, but there was a split among the demographics. So the older patients found the tangible easier to use because it was a box with buttons. They weren't scared of dropping an expensive device. The younger patients, where young means under 66, were more evenly split. A little over half preferred the tablet because of the aesthetic. It was more modern, and they preferred, the younger patients actually preferred the nurse asking them, but they said when you have to make a quick decision, the self-logging gave them more time. So they actually were a bit more reflective on that. Right, we'll go on to how it was used clinically to make some decisions. Ollie?
Okay, so we've actually been using this post-surgery on my ward in Milton Keynes University Hospital since 2016. This has generated a huge amount of data that we've been able to mine and process to answer certain clinical questions that I'm particularly needing of, and they can improve patient care. And we couldn't answer them till let's say now, with all of this data. So one example of a question that I've been interested in is knee replacements can be done with a tourniquet around the thigh to prevent bleeding during surgery, or they can be done without the tourniquet and you get a bit of bleeding, but there are certain other advantages. Previous papers had said that the post-operative pain, particularly during the inpatient stay, was higher if you used a tourniquet than if you did not use a tourniquet. And I wanted to revisit that question because we use something called a modern multimodal pain pathway. So a series of medicines, not just painkillers, that preemptively modulate and reduce pain, and if given early, can mean that the patient has less pain after surgery. So in a sense, I wanted to retest the old question, does a tourniquet cause more pain in knee replacement, when a modern multimodal pain pathway is used, and we used the PainPad data to show, in fact, that there was no additional pain when a tourniquet was used. A separate study that I was particularly interested in, my anecdote in this case, was that when I saw patients the morning following surgery, they didn't have much pain, everything seemed to be under control, but then they hadn't really walked much. And if I ever saw them the following day, they'd had a blip, a sudden surge in pain after they'd done all of the walking that day. And so in my mind, if I had a graph of pain for patients, it would vary around a mean on day 1 after surgery, but there'd be a sudden spike in pain on day 2. And sadly, the evidence, as is often the case when you do a proper scientific study, showed that this was just my anecdote and not actually what happened across large numbers of patients. So actually, I've already given you this information, haven't I? The tourniquet study showed no difference in pain when we used the PainPad data. There was quite a decent number of patients in this study, some 250 divided into 2 groups, half without tourniquets, half with equal demographics for both. And truly, with a modern multimodal pain pathway, no difference. But the PainPad was what generated this data. There's my non-existent blip of anecdote, and sadly I was wrong, but that's science for you, isn't it? Of course, Blaine, being forward-thinking and modern, was quite right. It had to be an app, and with greater acceptance of technology in the elderly patients, we have changed from using the tangible device to having a simple app on the home screen of the patient's digital device, be it an Android or an Apple device, both work. And it's the same PainPad with the same alerting you at certain time intervals and generates the same data. Advantage, however, the PainPad tangible device was really only useful in hospital because sending patients home with it meant they'd have to try and set it up with their router, and that was truly beyond the bulk of my patients. Whereas if it's on their mobile phone, it can continue to prompt them, and we can continue to get pain data that is in what I call the black hole. When my patients leave my hospital and my line of sight, I lose sight of them, and I don't know what pain they're in when they go home. And actually that matters to me, and the PainPad app generates that data for me, although this is fairly recent. And then once you've got it on an app, you realize that actually this thing is rather more adaptable than just 0 to 10 pain scores. You can get PROMs, patient-reported outcome measures, questionnaires effectively that are validated for certain medical conditions. And we use PROMs within orthopedics. So let's say someone's had a knee replacement. I'd use an Oxford knee score. It's a score out of 48. And the worse the score, the more trouble they're in. And I could, and we do, put PROMs into the app now, calling it the PromPad. However, it doesn't just have to be for orthopedics. Fellow research-interested surgeons in different hospitals have looked at other PROMs that relate to their specialty. I think those slides are coming up across the board, and I'll let Blaine tell you about some of that.
Yeah, so the just mentioning the other PROMs we're working on are for prostate surgery and complex airway surgery. So it can ask questions like how breathless you are, or if you have incontinence issues or things like that. So those are ongoing. But we also had interest from another part of the hospital in understanding chronic pain in children. And children, especially young children, found the PainPad device and the app quite boring. So we ran a co-design workshop where we brought children in who had had some experience of chronic pain. We gave them craft materials and asked them basically to design a pain logging device that was suitable for children. You can see some examples here from the session of the kind of materials we work with. So yes, computer science isn't always using a keyboard. We have plasticine, styrofoam, and pipe cleaners and everything it looks like you've been to a primary school. And they produced some really interesting designs, some of which we actually made into devices and brought back to test with them. But we got some also interesting insights from the children, different from the adult PainPad. We learned that surprisingly, children had a need to sort of prioritize privacy in social situations. So, for example, they would be using it in school. They wanted the ability to sort of have a device that would not sort of call them out as weird. Also, letting kids personalize device was important. So just as people put stickers and colors on their laptops and things, they wanted a way to personalize a pain logging device with different colors and shapes. And the other insight we had, different from adults, is the children felt they need to capture their overall well-being and not just how much pain they're in. So someone who's in chronic pain might have a day when their pain level's 8 or 9, but they're coping with it. So their overall well-being might be high, or they might have a day when it's 8 or 9 and they're just completely debilitated, and that would be a well-being score which is low. So it's not just a single one-dimensional aspect that we hadn't considered. So we'll talk about some of the work we're doing in development now. Ollie, do you want to talk about pressure source?
Yes, so leaving the PainPad and the PromPad to one side, there's a real problem, particularly in elderly, infirm, bedbound, coming into hospital, genuinely ill patients, that they can develop a pressure sore. A pressure sore is an area of your skin in contact with either the chair or the bed that is constantly under pressure, and if you're lying still and not moving, that area that's under pressure develops some ischemic change followed by some necrosis, some death of the tissue, and you can develop a hole in the skin, a pressure ulcer. It's a real problem for the country in that once you've developed a pressure ulcer, they are a nightmare to treat. They cost the NHS, both in the hospital environment and in community care with district nurses and dressings and treatments, they cost the country £5 billion per year. And there's no question, in the context of many things, but of pressure ulcers in particular, prevention is much better and cheaper than the cure. And it's proven in medical studies that if you just move, you yourself deliberately, or someone moves you for you, a nurse, a carer in a care home or a nurse in the hospital, every 2 hours or less, then that area where you're lying under pressure does not go on to form a pressure sore. So anything that can improve that dynamic, getting someone rolled 2 hours or less, frequently, 24/7, night and day, is going to reduce pressure sores for the country. So we thought, why not create a mattress adapter, something that simply fits on the mattress in the hospital bed that measures pressure, where the patient is lying, where the pressure is most and what position they're in, and time. So we need to know that the patient is lying still and has been moved less than 2 hours ago as a rolling fact. It also, as well as prompting, because we would have something that is from the pressure adapter at the end of the bed, a sort of a traffic light system at the end of the bed. Green, they've been rolled recently. Amber, it's been a while, it's coming close to the 2 hours. Warning, red, it's been 2 hours, you need to roll the patient now. And alert, light and sound, to the ward carers that the device has measured 2 hours and the patient needs to be turned. But it can also record this data that could go into the patient's own electronic patient record to show either way that either they've had excellent care, they've been rolled every 1 hour and never once was anything missed and they still developed an ulcer. That's terrible, but we definitely did a good job. Or the other way, which was that there was a bad night and there were periods of 3 or 4 hours when they weren't turned and then they went on to form a pressure ulcer. It's a record. Also, whilst I was moaning about various things to poor Blaine, whom I moan at a lot, when I was moaning about pain, I was also moaning about, well, I don't know when my patients take their painkillers. If only I had a device that I could put the painkillers in that would log when they took them, I would have objective, digitally collected data on their pain from the pain or PainPad and on when they took their painkillers and what dose. So I'd have two complementary graphs to give me a better picture of, is my patient in pain because they're not taking painkillers, or is my patient in pain even though they're taking painkillers? To me, this is useful information. So we've made a, oh,
We haven't, no. So we've
Yeah.
probably just mentioned
Yeah.
this is a design concept. We haven't
Yes.
actually made a functional prototype
That is
yet.
yours.
And it is so this is a concept that looks like a Pez pill, a Pez candy dispenser, and that was our inspiration at first. So this one is still in development. We haven't deployed it, but we do have a patent on it. So we are working on it this year. But the advantage is, Ollie, you can talk about the clinical uses of why that would be good.
Okay, so I need to know how much painkillers my patients are taking. And as is often the case when you think of something new, particularly in my case, I have a very narrow view. I wanted it to do one specific thing. But then the more we thought about it, actually, the more a cartridge in which you put your pills can have multiple uses and way more interesting and useful uses than just monitoring pain. For example, if you're a patient who has high blood pressure, you need to take your blood pressure tablets regularly and the right dose. If you're a cardiac patient, you especially need to take your cardiac medication to prevent cardiac complications. If you're a diabetic patient, although yes, diabetic patients can have injections, but most diabetics are type 2, which means tablets. They need to take their tablets at the right time. Same for Parkinson's and numerous medical conditions. And this is called medicine's compliance, when and if you regularly take the tablets at the right time. And to bring it to life, if a patient comes to their GP and says, my blood pressure is poorly controlled, it's very high, or it's been noted to be high when your nurse made the blood pressure measurements, the GP will say, well, what dose of medicine are you taking? Oh, frusemide 20 milligrams once a day. Okay, well, that's easy. We'll up it by 10 milligrams per day. You'll take frusemide 30 milligrams per day. Anyway, thank you, bye. Moves on. But what the GP doesn't actually know is if the patient's truly been taking their tablets and the correct dose and the correct frequency, or have they forgotten, do they forget 5 days out of 7, worst case scenario? And actually what they've done is react and change the dose when actually what they needed to know was compliance, and to encourage correct compliance and do another cycle of audit, if you like, measure the blood pressure again. If it's normalized, they don't have to change the dose. So it's data that the GP doesn't have for blood pressure, and you can apply that to cardiac, diabetes, Parkinson's.
So bring us around to what does this have to do with studying a STEM subject? Well, this was the meeting Ollie by this chance meeting 10 years ago. I never thought that I would then be working in digital health. I was a computer scientist, mostly doing work in privacy and security. But when we found this connection, it led to a cascade of all these various gadgets and inventions we've just talked about. So I think the point of our talk is that whatever subject you study, talking to people in other disciplines leads to interesting conversations, which may then find that you can solve problems other people have because there are connections between what you do and what they do. And so whether it's computer science, life science, maths, engineering, they all have the potential to improve health and healthcare, and many other things. You just need to look for those opportunities. And I think that's all we have to say, and we can go to questions now.
Wonderful. Thank you very much for that presentation and wrestle through the PainPad journey and other things associated with it. So we've had some really good questions in the chat. Please do continue posting them up because we have plenty of time for questions. So we'll start with what we have. I have a few prepared as well, and more than happy to pull anything else in. So the first question is, have you envisaged extending the PainPad to other types of surgery, such as ACDF? You talked primarily about knee and hip, but I know that that's not been the only use case, but...
Yes, and absolutely. Pain is pain, whatever its root cause. So it happens to be that my most easily available patient cohort are my patients. Therefore, selfishly, I've studied my patients. But we absolutely have, as you've seen in other parts of the talk, started spreading the use of the PainPad and its PROMS equivalent far and wide, and it has incredible uses. So any form of surgery, whether it's inpatient pain or outpatient when they've gone home, any form of medical condition that results in pain. There are patients with chronic pain, fibromyalgia, rheumatoid arthritis. I've just had a couple of chats with Versus Arthritis, which is a national organization that represents people with rheumatoid arthritis, amongst others, to use our PROMS and PainPad to collate data for them, for their end users as well. And clearly, it's just a useful tool. It is just a tool, and how you use it is what matters, but it's not just for orthopedics, it's for anything that involves pain or reported outcome measures as well.
Yeah, particularly anaesthetists have been interested because, of course, pain is their specialty. We've had one specialist anaesthetist interested in improving care after cesarean section. And we've done some studies of, some preliminary work on looking at mothers who've had a cesarean and monitoring their pain after that.
Yeah, so it is a tool that, if it was freely available, which we're doing our best to make it so, would have numerous uses.
Thank you. There's a couple of questions that I think are worth digging into around the lessons learnt from the design work with children and how that applies to adults. So the broadest sense of the question is, was there anything we learnt from doing the design work with the children that caused us to revisit assumptions we'd made around needs for adults?
Probably, I'd say the problem we gave the children was for chronic pain, and the particular condition that we were thinking of at the time was sickle cell anemia, where the location of the pain is important. So you might have seen on the designs, you saw a model of a body, and people could mark not just the amount of pain, the location it was in. In orthopedic surgery, we know where the pain is because you've cut them there.
Sorry, my fault.
But in many other conditions, you may want to know what part of the body and the intensity of the pain and many other qualitative characteristics. One of the disadvantages of working in a narrow discipline is that you only think about your own problems.
Yeah.
And I think, there are other medical disciplines where that.
Well, so other medical disciplines, but also, and it comes up with patients, and we discussed it on and off quite frequently when discussing the pain scores we got, is what were they doing when they logged their pain? And on a tangible device with finite uses for a finite number of buttons, you couldn't really say was mobilizing, wasn't mobilizing, had physiotherapy, didn't have physiotherapy, has recently had their painkiller, hasn't recently had their painkiller, sort of binary yes, no answers. And that was important to the children, as well as their location of pain, as well as their emotional well-being at the time, as what was important to them. And it did enable us to revisit that question. And the yes, no physio question is quite easy for us to resolve, I think, on the digital PainPad. You put your score in and a banner, a pop-up comes up and says, have you just done physio? Or have you just been walking? Or have you just had a painkiller? I think you can get questionnaire fatigue with too many of these things. But one of them, particularly the physio yes-no question, is very much of interest to my, again, narrow view of the world.
Yeah, one of the important things for us is engagement, or compliance is the medical word. And if you're, as you find with paper questionnaires, people will eventually get bored and stop doing them. Same with any questionnaire. If you give them a digital questionnaire or ask them too many questions or too often, they will just stop giving you answers. So you need to find for each person to tune the sweet spot for that person to get the minimum information you need with the minimum amount of questions.
So I know the question was, what did we learn from the kids that we apply to adults in a sense? What we have learned from the adults is, I don't know, in a broad sense, gamification. If we give them feedback in some form when they are providing pain data for us, then they have a tendency to continue for longer to input data. In this case, all they really need is what their pain scores look like on a little graph on their app live. And we've provided that now, and there's no question. It's going to be a feedback loop, positive reinforcement, that they will likely change their behavior. In one sense, they'll input more data, but in another sense, they may start to analyze when they had higher or lower pains, and they may change how they take their painkillers, something.
yeah, some reflection.
Yeah.
So then focusing in specifically on the well-being aspect, I know, Ollie, you were talking about the physio yes, no as being a more important element, but for adults with chronic pain, do you think that well-being distinguishment from pain would be an equally important thing to integrate in?
Yes. And so it's a very, very complex topic. Pain is not just pain. There's an emotional component to pain as well, and it's very hard to measure. In scientific, biological terms, your pain fibers go up a tract of your spine called the spinothalamic tract. The clue is in the name, meaning those tracts go through the thalamus, your emotional center, before they get to your conscious part of the brain. And your pain is felt differently under different conditions. If you are depressed or anxious one day, then what might have been a 5 out of 10 pain score might be felt as a 6 or a 7 or an 8 out of 10 pain score. If you're cold, pain hurts more. All sorts of things dial in to your subjective experience of pain. And it's a common criticism of any pain score is, well, hold on, Blaine may have an incredibly high pain threshold and you, Ollie, may be a complete wimp. And if I put a 10 Newton force through your thumbnail, Blaine may say, what 10 Newton force? And I may get 8 out of 10. But the truth is, if you have enough numbers, then the mean becomes useful. And what you really want is internal consistency. If you have your own numbers, my own pain chart over time, then my numbers compare to my previous numbers better than my numbers might compare to Blaine's or vice versa.
Thank you. There's another all of the questions are really interesting, but I know this is one that I don't think I have thought about with the work on the PainPad. Do you think it could be used to speed up diagnosis? The example given is for endometriosis.
Endometriosis.
Clearly, the answer is yes. And then it's the mechanics. Do you give PainPad apps out to every GP patient? There's not really much of a cost to it because it's digital. Do you then have a resource issue, meaning to whom do you give the task, the job of monitoring this data, and what do they do with it?
If I could, interrupt, I think for diagnosis for that particular condition, it may be the case that if they are self-logging their pain either with PainPad or another app, say one built into their phone, and show up for a GP appointment and can show the pattern of their pain, and maybe I don't actually understand how to diagnose endometriosis, but if it corresponded with a menstrual cycle and they could show the GP the pattern, they have a contemporaneous record to show. Without having any cost to the GP until they show up.
So it can facilitate diagnosis. It may even speed it up in certain cases. The problem with pain is that it's generic, it's broad. You can have pain from appendicitis, you can have pain from an ovarian cyst, you can have pain from endometriosis, you can have pain from trapped wind. The diagnosis isn't made just by pain, but let's face it, it's a facet and an important one. And if the self-logging of pain provides a pattern that the doctor there and then can use in their diagnostic process, I often think of it as a jigsaw puzzle, it's one piece of the jigsaw puzzle, then it's definitely helpful. So yes, I do think it's helpful.
Do you think using it will help reduce opiate use? It's a wonderful follow-on.
So all sorts of studies on pain have a facet called opiate sparing or opiate use. Meaning if you make an intervention, for example, injecting some local anesthetic in the knee just after you've done your knee replacement, it numbs it, and for 4 or 5 hours, you don't have to take quite such a high dose of painkillers, opiates in this case. And opiates have side effects. They can make you feel sick. They can drop your blood pressure and make you feel dizzy if you stand up. And these things can have a knock-on effect to slow down your early mobilization. Was it, however, the use of a PainPad or a PainPad app that reduced the opiate use? I don't know. There is definitely, with feedback to the patient who's entering their pain scores and seeing their own pain scores on their graph, it can have an effect on their behavior, timing of when they take their painkillers, which could secondarily be opiate sparing, maybe. So maybe.
And Where should we go next? We're going to stick a little while longer with some of the medical questions and then come back to some of the more technical questions. I think that's the way we'll progress through. So there's a question here about gender and whether we're gathering data on gender and having that as a component of our analysis, particularly given some of the gendered conceptions or misconceptions of pain. So could you talk about how we've handled that in some of the analysis?
Yes, it wasn't in our early agenda, pun intended, but it's data we have. And we absolutely can look at male, female, and age demographic, and all sorts that could dial into pain. So the beauty of this is that it generates an ongoing database that we can query, fishing trip as they call it, to gain answers that we want. So yes, we could.
I mean, Daniel, you've done a lot of the analysis. Has gender come up in any of the analysis you've done?
Not hugely, no. Not as significant contributing factors to any of the statistical separations we've seen, or lack thereof. So in the tourniquet data, we looked at age, we looked at gender, we looked at the surgeon as well, because it wasn't just Ollie.
That definitely has an effect, no question.
Definitely has an effect, but not a significant effect in terms of the pain data we were collecting. So it is part of the analysis we do routinely, but to date, we have not found it to have a significant predicting impact, and therefore no data that would inform treatment as a result, which really is, for all three of us, the main outcome of using the PainPad. It's an intellectual curiosity for Blaine and myself, but with the intention of actually helping patients at the end of the day is where we want to be.
Yes, it could easily dial into any number of projects we want. There's no question. I think that perception of pain across male and female sexes is similar, and we've shown that's what our data has shown. Side effect profile to medications is different in men and women. You have a greater side effect profile to opiates in females, not just to do with smaller body mass, but a higher rate of nausea and a higher rate of postural hypotension, dropping of the blood pressure after the dose of opiates. So in my patient cohort, which is actually 60 to 70% female who have their knee or hip replaced, they have more side effects if they're requiring more opiates. And it could be another yes, no in our PromPad question. Have you just had opiates as well? And have you had a side effect? It's the sort of thing that we can study because we have a tool.
So there's an interesting question here, which also highlights the need for interdisciplinary teams, because truly we need a psychologist on the team to answer robustly. But is there a risk that asking patients to rate their pain regularly leads them to focus negatively on it?
Yes. Next question.
And we do have psychologists on the team.
Yes, and we do. And clearly you don't want to take psychological advice from an orthopedic surgeon.
Or a computer scientist. We're all a bit autistic.
Shall we unpack that a little bit then? So
yes.
Particularly for post-surgical patients, is there a particular fear that focusing on the pain could emphasize it?
So there's no question that prior to surgery, one of the major things that patient nominate as what worries them is that they're going to be in pain. I actually think it may work the other way, not that we're focusing on pain, but that we're using a tool to measure pain that gives them some form of feedback and perhaps some degree of control with information structured in a nice, easy dashboard way for them. I wonder whether, in fact, it might be the converse, where they already, I absolutely guarantee it, they already focus on pain in an anxious fashion prior to surgery. You would not be human if you didn't, prior to something you've heard of being painful. After surgery, they don't need reminding. The pain's already there. It reminds them. So I'm not sure that our use of a tool to monitor pain in a simple fashion actually changes their mental aspect negatively. I have a feeling it might be neutral or positive.
Did you have any follow-up to that, Blaine? Or...
No, I'm not going to delve into the psychology area. Thank you.
Well, here is one you can focus on, because I know you've been putting some time into this with regard to a separate deployment somewhere else. Can you unpack a little bit some of the techniques we've used for keeping the data secure? patient data. It's very personal. It obviously has a need for being
Yeah.
kept
So
secure.
the most important technique we use is the general data protection technique of data minimalization. So everywhere it's collected at any hospital, the only link we have between the score they enter, whether it's a PROM like breathlessness or a pain score, is the local hospital identifier number. So every hospital you go to gives you a different identifier number, which is not your NHS number, and we definitely don't store that. So we just transmit this local hospital number and the data stored in again, obviously a secure database, and we make that available to be entered back into the medical records when that system allows us to connect to it. But only someone who's able to match a hospital record with a name, and that's quite secure. There are very few people who can do that, can get the data. So it's basically secure by minimalization.
Thank you. Here's an yeah, okay. So LLMs and generative AI has been very much in the news. Do you think any of these recent developments in artificial intelligence techniques will help improve any of the array of digital health projects we're working on?
Yes.
Yes. Probably.
Again, would you like to unpack?
Okay. Well, I mean, actually, Daniel, we would probably pass that to you as you've been doing more LMM work than we have.
So in terms of the recent advances in terms of generative AI, and particularly the conversational techniques which are present in large language models, they have a huge array of possibilities in terms of facilitating interactions between patients and clinicians. But underlying them, you're much more likely to be relying on an older form of machine learning called expert systems, which have deterministic routes through decision making, in which it's much easier to ensure that the advice that's being given out is predictable and accurate. Whereas with LLMs and a lot of the conversational tools like ChatGPT or Copilot, they're unpredictable. And in the medical domain, there's a whole host of examples in recent times of them giving out poor advice. We do work with a colleague, Mohammed Benassar, who's also based in computing and communications, on a number of machine learning techniques, which Blaine has been more involved in and perhaps unpack
Yeah. So as opposed to LLMs, machine learning techniques don't hallucinate answers. And we've used these kind of techniques to look at historical data and find interesting patterns, for example, in cardiology, to understand who needs to have an echocardiogram so we can prioritize them because they're most likely to have a heart problem. And there's other work that's been done where machine learning has been able to do things like look at X-rays, thousands very quickly, and be able to prioritize them. So only the really tricky ones need to be seen by a human radiologist, or even to classify and catch cancers. So those sorts of techniques, those sorts of machine learning techniques have been more productive. In terms of the things you've heard of with LLMs and chatbots, those sorts of things, I think we do see a role for them. Particularly in the orthopedic surgery journey, I think after surgery and even pre-surgery, where patients are trying to get information about, say, from a physiotherapist on whether an exercise they should be doing it or not, and they can't just reach the clinician, the physiotherapist directly. An LLM chatbot can probably filter things and give them a kind of conversational answer that sort of gives them enough information that they don't injure themselves until they can talk to a human. There are probably other applications of that, but the problem is, as many of you know, the hallucination effect, where the chatbot goes off in a tangent, possibly in a medically incorrect tangent, is a huge risk. So I think we're very wary of that.
Yeah, so I separately to this project use a predictive AI model based on an app that my patients have that monitors various parameters after their hip and knee replacement, such as step count, such as period of time immobile.
Gait length.
Yeah, and gait parameters as well, whether they're limping. to predict, based on a large database of preceding patients, whether in 3 months' time they're going to be within 2 standard deviations of what is considered normal recovery, or whether they're going to be outside of them. And it's useful as what they call an exception report for a clinician to be alerted that someone looks like they are in some form of trouble as based on the limited parameters that are being measured, and it identifies them. What do we do with that information? Yes, you could use a chat bot to contact them, but actually we don't. We go a bit more analog. We phone the patient. Is there a reason? And is the reason medical and related to me that I can do something about, or is it that they've recently been bereaved, or they're having work done in their lounge and they can't walk as much as these? There are various non-medical reasons for step count and gait parameters to go down after surgery if you measure for long enough. So we found actually phoning the patient to be a very useful screening tool when they've been exception reported.
Which links wonderfully into one of the other questions we have, which I'll send to Blaine first, because I know he's done some work around this, around using fitness type technology, commercial wearable fitness technology, and using it as a preventative tool rather than an assistive tool after a medical condition has become embedded. Do you want to talk through some of the work you've done?
Yeah, so this is actually I think the very first project, well, the second one after PainPad that Ollie and I did working together. We used a very inexpensive Fitbit tracker that we gave to patients to monitor their step count after surgery, because we want to see how active they were after surgery and understand if we can solve one of the great mysteries of knee surgery, which is why no matter who does the surgery, do about 20% of patients not have a successful outcome a year later. And we were hoping to discover if perhaps the ones who were inactive early after surgery were the cause, or they were overactive. So we didn't actually find an answer to that question, but it did lead to using the fitness trackers to understand how other things work and how to improve engagement with patients. So that was more of a trigger at that point. Now, as Ollie said, one of the apps that patients get that are given out by his hospital uses the phone's accelerometer to measure things automatically. I think the main issue with fitness trackers is the step count they give is very inaccurate depending on where they're worn. If they're on your wrist, they're making a guess based on your arm movement. If they're on your hip or another part of your body, then they'll have another guess. If they're in your phone in your pocket, it's another measure. So it really is kind of medically useful using the data, but your average fitness tracker probably isn't suitable.
Wonderful. So we're heading towards 1 o'clock, which means it's a good time to move towards some future-looking type questions. So there's some really interesting ones here. If you could create a health device to cure one ailment, what would it be? Or treat or prevent? I think we'll unpack cure a little bit.
Well, we presented it really. The one I hold out, the two I hold out the greatest hope for genuinely making a difference is the pressure pad in particular, but the pill pad, if it was broadly adopted for medicines compliant, would improve the health of the nation. Full stop.
Yeah, I think if it was just if all medicines came in a standard cartridge that fit into a device that you could carry and put in your pocket, your handbag, and automatically logged when you took it, and was cheap enough to just be generic and all packaging came that way, then the data would be invaluable, not only for compliance, but for research, because you could fine tune, you could personalize medicine, because everyone's reaction to medicine is different based on their body size, type, and physiology. So you could start fine tuning the treatment if you knew exactly the effect after the medicine was taken.
Yeah.
And the savings, again, for pressure sores, it would be a crazy savings.
Well, so that's financial, but the patient experience of having to have dressings on a painful pressure sore for 2 or 3 years afterwards, and constantly having visits from the district nurse, and the odor, the whole experience thing is very poor. And if we could prevent it, it disappears.
Yeah.
So where do you see the PainPad being in 10 years' time?
Probably the physical device will probably be not used widely, other than in very restricted cases of people who have who just can't use a virtual device. And I think it will just be, it won't be a PainPad, it'll be a generic problem pad where you can ask any question that's relevant, not just pain.
Yes. Yeah, we see it being, until the ubiquitous smart device gets superseded by something else, we see it sitting on there.
And a lovely question to wrap up on then. What is the future for people's self-logging data for medical purposes? What does the future look like? So the mobile phone, as Ali's just said, is the current.
So the future is not just going to be self-logging, really, isn't it? It's going to be data collected by tools. If we're really being science fiction about it, embedded sensors, nanotechnology, all of which uploads blood pressure measurements. The very short-term variation in blood sugar is a really good example in the diabetes world, where they have these patches now that will monitor, albeit not blood sugar, but extracellular fluid sugar, and it's related by within a few minutes. They've found that short-term variability is associated with very poor diabetic control, where before you used to do, I don't know, 3 tests per day if you were a good diabetic patient of your finger prick, and it had completely ignored the short-term variability in between time, and it wasn't even a factor that was being measured. So yeah, not just self-logging, but short-term measuring of interesting parameters.
And I think getting away from self-logging to automated, because the more that the less the human has to do, the less that compliance and engagement is a problem. So your toilet may just monitor everything and report the data. The devices around you may do things, all those things automatically. And then, of course, we have privacy issues, but that's another topic altogether for another talk.
Objectively, digitally collected data.
Objective, yeah.
Wonderful. Thank you very much, both of you. That's all of the questions we have.
Mm.
Did you want to wrap up with a short
takeaway
message?
Yes, it's been a journey, and it's been a partnership, and it's not over yet. And the more projects that Blaine and I do together with his team, the more projects it prompts us to suddenly think are a great idea, and we're just never going to sleep.
Yes, so if you're interested in doing this kind of work, then there's a great future, because we have more work than people. So we look forward to welcoming people to join the team.
Summary statement, please help. Come.
Wonderful. Thank you. And I think that concludes our Ask the Expert session for today. So thank you very much for joining us. I hope you found it interesting, and that you join future Ask the Expert sessions here at the Open University. Thank you very much.